Prevention and treatment of delirium in hospitalized patients. Delirium is extremely common, vastly underrecognized, and poorly managed. Delirium in hospitalized patients is linked to higher rates of mortality and morbidity, as well as increased lengths of hospital stays. Diagnostic criteria for delirium. The presence of delirium requires all the criteria to be met. Disturbance in attention and awareness. Disturbance develops acutely and tends to fluctuate in severity. At least one additional disturbance in cognition. Disturbances are not explained by a pre-existing dementia. Disturbances do not occur in the context of a severely reduced level of arousal or a coma. Evidence of an underlying organic cause or causes. Confusion assessment method. The presence of delirium requires features 1 and 2 and either 3 or 4. Acute change in mental status with a fluctuating course, inattention, disorganized thinking, altered level of consciousness. Factors that complicate delirium recognition. Inadequate education for staff, lack of time and staff, history of dementia, increased patient acuity, history of hearing and vision deficits, fluctuating symptoms of delirium. Indicators of delirium to document. Confusion, disoriented, altered mental status, inappropriate behavior, mental status change, inattention, hallucinations, lethargy, agitation or restlessness, poor historian. Studies proved that CAM was a reliable tool for diagnosing delirium. Dallin did a study that reviewed 34 charts which showed that nurses and physicians failed to document symptoms. Failure to use standard language for delirium symptoms prevents the proper referral for patients. Lack of documentation may compromise patient follow-up care. The statistics. 1/3 of general medical patients who are 70 years of age or older have delirium. Delirium is the most common surgical complication among older adults. 15 to 25% after major elective surgery and 50% after high-risk procedures. The prevalence of delirium at the end of life approaches 85% in palliative care settings. The incidence of delirium exceeds 75% in older adult patients undergoing mechanical ventilation. Delirium is present in 10 to 15% of older adults in the emergency department. Risk factors, classified into 2 groups, predisposing and precipitating factors. Predisposing factors include older age, dementia, functional disabilities, high burden of coexisting conditions. Precipitating factors include medications, surgery, anesthesia, increased pain levels, anemia, infection, acute illness, acute exacerbation of chronic illness. Delirium prevention. Prevention programs can not only reduce odds of delirium by 30 to 40%, but it may also reduce complications associated with delirium to include falls, increased functional impairment, increased length of stay, and pressure injuries. What's included in delirium prevention? Multidisciplinary teams, trained volunteers, family education, and family involvement in care. An example of a delirium prevention program in Australia is the Eat, Walk, Engage program. They utilize a structured framework to support functional independence, early mobility, meaningful cognitive activity and engagement, enhanced nutrition and hydration. One unique part of this program is it includes patient interviews to inform and evaluate this program, as well as let the patient's voices be heard. Non-pharmalogical treatment and prevention of delirium. Frequent reorientation with cognitive stimulation by nurses and family members have been shown to reduce length of stay and decrease duration of delirium. Having family involved and trained in assisting in the care for elderly patients at risk for delirium has also decreased family anxiety. Providing patients with props and having family bring familiar items accompanied with extended family visits decreases the incidence of delirium and falls. Family members calling and recording messages for patients to listen to during waking hours has shown higher numbers of delirium-free days. Studies have shown that caregivers' involvement in interventions for delirium, hospital stays were decreased by 4 days on average. Family involvement is free, absent of side effects, and efficient. Many caregivers feel more confident in caring for their family member when they are sent home after they have been involved in their care in the hospital. Early diagnosis of delirium is the key to reversing delirium course, preventing immediate and long-term complications, conserving healthcare resources, cutting costs, and improving quality of life for older adults and their families. Pharmalogical treatment. Most studies have shown that the use of antipsychotics to treat delirium in older patients is not beneficial. It increases the length of stay, complications, and mortality rates. Antipsychotics and other sedating medications should be used only if the patient is severely agitated or a harm to themselves. Medications that may be used. Antipsychotics, typically considered the medication of choice. These include haloperidol or risperidone. Benzodiazepine, not a first-line medication, can cause excessive sedation. Lorazepam. Cholinesterase inhibitors, donepezil. Melatonin-based, Ramelpion. Others include ketamine. Thank you for your time.